So good morning, everyone. So welcome to the Physiotherapy Scholarly Panel of the conference It's About People. My name is Tina Kovačič. I'm Assistant Professor at Alma Mater Europaea University, and I have a pleasure of moderating this session. So today's panel highlights the growing scientific and clinical relevance of physiotherapy research, reflecting how our profession continues to develop through evidence-based practice, through interdisciplinary collaboration, and through clinically applicable research. So the studies presented today span topics from spinal deformities and neurological injury to cardiac rehabilitation and sports performance. Before we begin, just a brief note on time management. We have several excellent presentations scheduled, and in order to ensure fairness for all speakers and to allow time for discussion, each presentation will be limited to a maximum of 10 minutes. So to help you with timing, I also will give presenters a gentle reminder when there is 1 minute remaining. So I kindly ask really all speakers to conclude their presentation within this time frame, as we cannot extend the session beyond the scheduled time. So really thank you in advance for helping us keeping the session running smoothly. Let us begin with our first presentation. So the first study explores the comparative effectiveness of different physiotherapeutic exercise approaches for idiopathic scoliosis in adolescents and young adults, focusing on spinal mobility, trunk deformity, and psychological outcomes. The presentation is titled Comparative Effectiveness of the Schroth Method, Core Stabilization Exercises, and Pilates on Spinal Mobility, Cosmetic, Trunk Deformity, and Psychological Factors in Adolescents and Young Adults with Idiopathic Scoliosis. So the presenting author is Shkurta Malai, PhD candidate, currently also pursuing additional doctoral research in physiotherapy. So Dr. Shkurta, the floor is yours.
Thank you very much, Professor Tina. So again, I'm Shkurta Malai. I work as a physical therapist at University Clinical Center of Kosovo in the Physical Medicine and Rehabilitation Clinic. And I also work as a teaching assistant at University of Pristina at the medical faculty in the physiotherapy department. And in the same time, I am a PhD student at Alma Mater Europaea in Maribor. And the study which I will present now is titled Comparative Effectiveness of the Schroth Method, Core Stabilization Exercise, and Pilates on Spinal Mobility, Cosmetic Trunk Deformity, and Psychological Factors in Adolescent and Young Adult with Idiopathic Scoliosis, and Narrative Review. So as we know, idiopathic scoliosis is a quite common spinal deformity that affects up to 5% of children. And by using the word idiopathic means that the causes are unclear or not associated with any particular syndromic, congenital, or neuromuscular disorders. Based on the age, we know that ES classifies as an infantile, juvenile, adolescent, and young adult, where adolescent idiopathic scoliosis presents the majority of all scoliosis cases. And we know that girls are affected 3 times more than boys. Regarding the definition, what is idiopathic scoliosis? So it's a 3-dimensional deformity of the spine, which means we have a deformity in 3 planes, so in frontal plane, in sagittal plane, and in a transversal plane. And it is called as a scoliosis if the curve angle is up to 10 degrees. Regarding the clinics, so we know idiopathic scoliosis causes several problems, such as trunk asymmetry, can reduce spinal flexibility, muscles imbalance, in some cases can cause back pain, which then negatively affects quality of life and psychological well-being. And in severe cases, also pulmonary complication may also occur. So knowing the consequences of idiopathic scoliosis caused, so the first step of treatment is physiotherapeutic scoliosis-specific exercise and brace. And the aim of this conservative treatment is to stop or to slow the progression of the deformity. PSSE should follow the SOSORD guidelines and should be individualized based on patient's need, curve orientation, curve angle, age, and treatment phase. So various exercise-based interventions are used to treat mild and moderate idiopathic scoliosis, including stroke exercise, core stabilization exercise, and Pilates exercise. And in this slide, I have presented the focus and the key outcomes of mentioned method. And as we see that stroke exercise, the focus of this method is in 3D corrective spinal movement, while core stabilization exercise, the focus is to activate the deep trunk muscles and postural control, and Pilates exercise focused on core strength, posture, and breathing control. And then key outcomes of all these three treatment method is to stop or to decrease, to stop improving or to decrease the curve angle of trunk rotation by improving waist asymmetry, spinal appearance, then pulmonary function, improving flexibility, also decreasing pain, and overall improving the quality of life. Although there are evidence which support the use of each treatment method in treating idiopathic scoliosis cases, however, comparative evidence between stroke exercise versus core stabilization exercise or stroke exercise versus Pilates exercise remains limited, particularly for multidimensional outcomes such as spinal mobility, trunk appearance, psychological well-being, and quality of life. So limited evidence suggests that stroke exercise and core stabilization exercise may both improve curve angle, but clear conclusion about their comparative effectiveness are still lacking. So based on this, the aim of this narrative review was realized to compare the effect of stroke exercise versus core stabilization exercise or stroke exercise versus Pilates exercise on spinal mobility, trunk appearance, cosmetical trunk appearance, psychological outcomes, and quality of life in cases with mild and moderate idiopathic scoliosis. Materials and methods, searching strategy. So a literature search was conducted in Pedro, PubMed, and Google Scholar for studies published in the last 10 years. And methodological quality of studies was assessed using the Pedro scale, and outcomes including curve angle, angle of trunk rotation, spinal mobility, cosmetical trunk deformity, psychological factors, and quality of life. Here in this slide, I have presented the searching strategy, combining relevant keywords and mesh terms. And the detail how the searching strategy is realized in each database are presented in Appendix 1. So the searching strategy was realized between November and December 2025. And this review was realized following the GPI guidelines. Eligibility criteria. So eligibility criteria was structured according to PCC framework, population, concept, and context. So the population consists of adolescent and young adults with mild and moderate idiopathic scoliosis. The concept including exercise interventions such as stroke, core, or Pilates. And the comparison included stroke versus core or stroke versus Pilates, and the context required that study were required to report outcomes related spinal mobility, cosmetical trunk appearance, psychological outcomes, and or quality of life, in addition to primary structural deviations such as curve angle and angle of trunk rotation. So studies included if they were investigate the effect of stroke versus core or stroke versus Pilates in cases with mild and moderate idiopathic scoliosis, and except curve angle and angle of trunk rotation, also study which reported outcomes at last one of the following parameters like spinal mobility, cosmetical trunk appearance, psychological outcomes, and quality of life study, which were published in English, randomized control trial study, clinical trials, or clinical study as they design. Studies excluded if they were case report, case year review article, letters to editor, or conference abstract, if they were in animal or in vitro study, or which published more than 10 years ago. So the result, the database search identified 480 records. In Pedro, we identified 24 studies, in PubMed 19, and in Google Scholar 437. And in this figure, I have presented the study selection process. And if you see that at the end, only 4 studies met the inclusion criteria and were included in the study. So the quality of the included study was assessed using the Pedro scale. And as we can see, one study by Kotzmann et al. Demonstrated strong methodological quality with a score of 8 to 10, while 3 other studies by Liu et al. And Kim and Havenbo demonstrated moderate quality, each scoring 5 to 10. So the mean Pedro score across the included study was 5.7 to 10, indicating the overall moderate methodological quality. In this slide, I have presented the characteristics of the included study. And as we can see, one study was retrospective cohort, so Liu et al. In 2025, which present the level of evidence 3, while 3 others, Kotzmann et al., Kim and Havenbo, were randomized control trial, and the level of evidence was 2. The study by Liu et al. Compared Schroth exercise versus spiral stabilization exercise versus core exercise, while Kotzmann et al. Compared Schroth exercise versus core exercise, and Kim and Havenbo compared Schroth exercise versus Pilates exercise. And based on the results which are presented in this table, so across all studies, Schroth exercise groups show statistical significant improvement in Cobb angle, angle of trunk rotation, spinal mobility, cosmetical trunk deformity, psychological outcomes, and quality of life compared to the core or Pilates groups. Discussion. So this review, as we mentioned before, included 4 studies comparing the effect of Schroth, core, and Schroth with Pilates in adolescent and young adult with idiopathic scoliosis. So the total number of patients which were included in this 4 study were 129. So mostly of them were female with moderate Cobb angle, scoliosis like Cobb angle 10 to 40 degrees. So 3 studies were randomized control trial, and 1 study were retrospective for studies. So overall methodological quality ranged from moderate to high, but the limited number of study and small sample size reduced the generalizability. So intervention duration varied from 2 weeks to 12 weeks. And at the end, overall findings, all exercise intervention improved Cobb angle trunk rotation, spinal mobility, cosmetical trunk appearance, psychological well-being, and quality of life. So Schroth exercise generally produce improvement in Cobb angle of trunk rotation, trunk symmetry, postural alignment, also great improvements in quality of life and psychological outcomes, while core show meaningful improvement were more for peripheral muscle strength, and Pilates demonstrate moderate improvement in structural and psychological outcomes. In this table, I have presented the limitation and clinical implication. As a limitation of this study, the small sample size, then a small number of study, also short follow-up, while as a clinical implication of realizing this study, we can say that Schroth exercise show greater improvement except in Cobb angle and angle of trunk rotation, also in other parameters like spinal mobility, trunk appearance, trunk psychological outcomes, and quality of life. While core exercise mainly improve muscle strength, and Pilates exercise provide moderate structural and psychological benefits. So short exercise recommended as a primary intervention for mild and moderate idiopathic scoliosis. Also, a multi-modal exercise program may optimize structural function and psychological outcomes. So as a conclusion, we can say that short exercise may provide broader benefits for cases with idiopathic scoliosis, except improving co-angle and angle of trunk rotation also can improve spinal mobility, trunk appearance, psychological outcomes, and quality of life. However, evidence remains moderate due to small sample size, short intervention, and variable protocol. So for the future, well-designed and randomized controlled trial with longer follow-up are need to confirm the long-term of effectiveness of this treatment method. Here are references. Thank you very much.
So, Dr. Skurta, thank you very much for this interesting narrative review. We will collect questions for the discussion at the end of the session. And while the next presenter is preparing the slides, let me briefly introduce the topic of next presentation, which addresses early rehabilitation following traumatic ulnar nerve injury. So highlighting the role of interdisciplinary physiotherapy and other approaches. So the presentation is titled 5-Week Structured Physiotherapy and Occupational Therapy Plan for Early Rehabilitation After Traumatic Ulnar Nerve Injury, a Case Report. The presenter is Mimoze Zogay, PhD candidate. So Mimoze, the floor is yours.
Hi everyone. Hi dear Professor Tina. Hi my colleagues. I'm Mimoze Zogay, physiotherapist, lecturers at the University Faculty Alma Mater Europaea, Campus College Rezonanța, physiotherapist at the University Clinical Center of Kosovo, 5 weeks structured physiotherapy and occupational therapy plan for early rehabilitation after traumatic ulnar nerve injury, a case report. Peripheral nerve injury is caused by trauma of fracture after 2 to 3% of patients in a level 1 trauma centers and often lead to significant disability. The ulnar nerve is one of the most frequently and severely injured nerve of the brachial plexus. Due to the limited muscle and bone protection, the ulnar nerve is particularly vulnerable to traumatic injury. Injuries commonly result in a sensory and motor deficit affecting the forearm and hand function. Clinical and function impact. Ulnar nerve injuries may lead to the intrinsic muscle weakness, loss of thumb adduction, and reduce I'm sorry, I can't see my presentation.
We see your presentation, so just continue, Mimoze.
Okay. A sensory deficit occurs along the ulnar border of the hand, affecting haptic feedback and precision tasks. This impairment significantly limits activities of daily living. Following surgical repair of the median and the ulnar nerve, only 15 to 60% of patients regain full function after 6 months rehabilitation. Rehabilitation challenges. Various rehabilitation strategies have been proposed to enhance recovery after peripheral nerve repair. Interventions such as interferential therapy, peripheral magnetic stimulation, exercise therapy, sensory education, and ergotherapy may support actional regeneration and functional recovery. However, evidence regarding combined rehabilitation approach is in a human mind limited. This limitation highlights the need for additional therapeutic strategies to emphasize recovery after peripheral nerve surgery. Peripheral nerve injuries are common in young adults, highlight the importance of early structured rehabilitation. Approximately 25% of patients fail to return to the work with 18 months after surgical repair of upper extremity nerve injuries. Delayed return to the work is common after ulnar nerve rupture, essential in case involving extensive surgical procedure of a manual labor. Rehabilitation approaches such as interferential therapy, peripheral magnetic stimulation, exercise therapy, sensory education, and ergotherapy may support recovery. However, evidence on a combined rehabilitation in human remains limited. The case representation, 25 years old, male with no significant medication history, sustained traumatic laceration of the right forearm caused by a failing window pane, admitted to the emergency clinical and the University Clinical Center of Kosovo. Multidisciplinary evaluation by plastic surgery, vascular surgery, and orthopaedic surgery was done. After that, the diagnosis was incisive wound of the right lateral forearm, complete section of the right ulnar artery and ulnar vein, completed section of the right ulnar nerve and the flexor carpi ulnaris. Surgical management was done in the emergency surgery under general endotracheal anesthesia. Surgical procedure was done reconstruction of the right ulnar artery with end-to-end anastomosis, ligation of the right ulnar vein, neurography and myography with direct suturing immobilization with gas was done for 1 month. Postoperative courses was done successful with no complication. Medication under during hospitalization that patient was used, it was antibiotics, anticoagulants, analgesics, and wound care daily from nurse. As an initial rehabilitation assessment, patient was recruited to the clinic of the physical medication and rehabilitation after 1 month surgery. Complication after reduced grip strength, impaired fine motor control, paresthesia and sensory deficits, handless hypersensitivity. Function evaluation quick dash score was 100%. As a complicated disability of right hand. Clinical assessment tools was done range of motion, manual muscle test, 2-point discrimination, joint mobility, 4 fingers. Diagnosis confirmed right ulnar nerve motor and sensory deficits secondary to axonal injuries. A timeline with physiotherapy intervention and clinical outcomes in post-surgical nerve recovery. Baseline was a nerve injury. In the first week was the surgical intervention. After 1 month, patient transferred to our clinic for a rehabilitation program. Baseline was done assessment is a baseline structured rehabilitation protocol. In this structured rehabilitation protocol, patients stay in our clinic for 5 weeks and to hold the intervention physical therapy for 5 sessions per week, 2 times per day. After that was done follow-up examination and a final return to the function. As a result of the initial assessment, in the inspection, in the forearm, patient had a well-healed cicatrix, approximately 30 centimeters of the right forearm, mild hand edema. And in the elbow, full range of motion, no significant infection, and in the elbow and shoulder was a normal mobility. In the worst, pronation was minus 20 degrees, supination was in a full, palmar flexion 30 degree, dorsiflexion 20, degree, radial deviation 10 degree, and ulnar deviation 35 degree. Movement markedly restrict, especially in flexion and the extension. Digital from 5 to 5 from 4 to 5. Deep and pip flexion 90 degree, distance raised fingerprint 7 centimeter flexion and 10 centimeter extension. Limited function, movement weak grasp. And DGTT, distance right fingerprint 6 centimeter flexion, 20 centimeter
Just to
extension.
remind you, 2 minutes remaining. Thank you.
Significant limitation of flexion and extension. Sensory evaluation, marked as an hyperesthesia and paresthesia and the ulnar nerve distribution. 2-point discrimination, poor discrimination ability, indicated sensory deficit, form sign negative, grip and motor control, several dimensions, inability to grasp and release effectively, indicated poor function recovery. A function assessment with the quick dash score was 100%, complete disability of the right hands. Regarding to the EMG, several lesion of the ulnar nerve. Treatment plan and comprehensive rehabilitation progress, weeks 1 to 5. In week 1, passive range of motion, edema control, gentle sensory stimulation. Week 2, initial of the active movement, soft mobilization, combined sensory restraining. Task in the week 1 was interferential current therapy, peripheral nerve electrostimulation. Interferential therapy was used with the bipolar with 2 electrodes. Also, peripheral nerve was used with the 2 electrodes bipolar devices. All these devices was used in 20 minutes for 2 sessions per day. All the settings and methods are in the regarding to the literature. Mild several points pain reduce in limitation active motion in the clinical observation in the first week. In the second week, initial of the active movements. Every task and devices was used as in the week 1. This interferential and current therapy was used for 20 minutes per session. Electrode was placed on the forearm. The important improvement, the important clinical observation was to improve first flexion, slight improvement, and grip imitation. In the week 3, progressive strengthening and proprioceptive training, coordination exercise was done. Also was used interferential therapy and peripheral nerve electrostimulation. Progressive with strike grading resistance exercise, elastic bands and weight put was used. Settings 3 sets for 3 times in 15 repetitions per week, gradual progression. In the week 4, continues like is the week 3, functional task training, advancing fine motor and control activities. L session approximately was in at 60 minutes per session. And the week 5 advanced the strengthening exercise targeting ulnar intermittent muscles, interossei and lumbrical nerve muscles. Fine motor dexterity training, manipulation of a small objective, precise grip and the task. Functional task-oriented therapy, improving hand coordination and endurance. Sensory education with graded text to discrimination of location task. Occupational therapy with emphasis on reintegration into a complex daily activity life. Adaptation, ulnar heating, sensory and motor function. In the clinical observation, in the week 5, continued improvement in grip, initiation and pinch control, increase endurance during functional hand tasks, notable reducing in sensory distributions with improving tactile localization, better performance in coordinated movements and fine motor tasks, touch still functionals.
Sorry to interrupt, Mimosa. Please start wrapping up your presentation. Thank you.
Okay. As we can see, extension, flexion, and finger before and after rehabilitation. In the first photo are before and before rehabilitation, the position that patient comes to us. The second and the third was full extension and the full flexion of the hand. Hand and finger movements recovery. The hand was in a full recovery function. Restoration of thumb opposition. Patient can do the opposition for all the thumbs. Functional grip before and after rehabilitation. Patient can do every fine motor activity. A functional recovery and fine motor movement can do. In the conclusion, a structured 5-week rehabilitation program combining peripheral nerve electrical stimulation, progressive strengthening, sensory education, and task orientation functional training results in a sustainable neurological and functional recovery. The patient demonstrated restoration of muscle strength in ulnar intervented muscles, normalization of sensory function, improved fine motor control, and full upper limb functional performance. Additionally, the sensory stimulation threshold decreases from 32 milliampere at baseline to 30 milliampere by the 3rd week, indicated increased neural sensitivity and improvement in neuromuscular responsiveness during the rehabilitation period. This find suggested that the targeted and progressive rehabilitation approach may facilitate the recovery of ulnar nerve function and hand dexterity. Recent studies indicate that the peripheral nerve electrical stimulation can enhance neural excitability and promote neuroplastic change, contributes to the functional recovery. Support the clinical observation in this case report. Although peripheral nerve electrical stimulation was associated with a reducing in the sensory stimulation threshold and improved sensory recovery in this case, the relationship between stimulation intensity and change in neural sensitivity is not yet clearly established in the literature. Therefore, further research should investigate whether change in electrical stimulation threshold may serve as a potential indicator of neural recovery during rehabilitation. As a clinical message, early multimodal physiotherapy includes peripheral nerve stimulation, progressive strengthening, sensory motor retraining, and ergotherapy may significantly enhance functional recovery and ulnar nerve reintegrating in the upper limb. References. Thank you so much.
Thank you, Mimosa, for sharing these insights from the case study. We will now continue with the next presentation. So while the next presenter is preparing the slides, let me briefly just introduce the topic of the next presentation, addressing cardiac rehabilitation following minimally invasive mitral valve surgery. So a topic of growing relevance in contemporary cardiovascular physiotherapy. So the presentation is titled Cardiac Rehabilitation After Minimally Invasive Mitral Valve Surgery in a Patient with Barlow's Disease, a Case Study, prepared by Marin Buljan and Sena Bogdanovic, and it will be presented by Marin Buljan. So please begin, the floor is yours.
I'm sorry, I said thank you very much for very nice and complete bringing in to my topic. So let's get started. What is the Barlow disease? It's basically a degenerative disease of a mitral valve, which includes myxomatous changes on leaflets of the valve and elongation of chordae tendineae of the valve and the dilation of the annulus of valve. And all of these symptoms of these changes brings one symptom, which is mitral regurgitation, which is basically retrograde blood flow from the left ventricle to the left atrium during systole. Chronically, it will lead to volume overload and progressive dilation of the left atrium, including eccentric left ventricle remodeling. And this brings all of this brings to a risk of atrial fibrillation and pulmonary hypertension. That's why the early intervention prevents irreversible myocardial damage, and it is important to make something about this in time. This case is important because severe primary mitral regurgitation significantly affects functional capacity. Timing of surgery is crucial to prevent irreversible remodeling of the left ventricle. Minimally invasive mitral valve repair is increasingly preferred. Cardiac rehabilitation is essential for optimal long-term outcomes, and physiotherapy plays a great role in the recovery trajectory after this kind of surgery. In this case, we've had a 61-year-old male classified in class 2 by New York Heart Association, which means that he had no symptoms while he was calm, but while doing some activities of a daily life, he had symptoms like dyspnea and everything else. He was diagnosed with severe mitral regurgitation because the area of regurgitation was greater than 40 square millimeters and the volume of regurgitation was greater than 60 milliliters. The important thing, he had a preserved ejection fracture, which meant that his left ventricle was okay still, but knowing the progressive symptoms of Barlow's disease, a decision was made to make an early mitral valve repair before dysfunction of the left ventricle. That is very important. The way to do this was decided to make a right mini thoracotomy, and including the coaptation, making the coaptation rate of the valves leaflets. There was made an annuloplasty ring, and chordae tendineae were made by PTFE. Shown to provide this kind of operation is shown to provide outcomes comparable to conventional surgery while offering several advantages related to recovery and rehabilitation. Compared to sternotomy, this kind of surgery leaves less surgical trauma, preserved sternal integrity, reduced postoperative pain, shorter mechanical ventilation, faster mobilization, earlier rehabilitation start, and better cosmetic outcome. The important thing for physiotherapy is earlier functional activation. Cardiac rehab started within 24 hours post-operative with the respiratory physiotherapy, education of diaphragmatic breathing, incentive spirometry, calf techniques, early verticalization, active limb mobilization, short corridor walking, and progressive increase in ambulation distance. The patient leaves hospital educated with the individually tailored exercise program, which he's supposed to do until he comes to the next stage of the cardiac rehabilitation, which is stationary rehabilitation. Before rehab, the patient has went through baseline functional assessment. He had a BMI of 29.3, and in a 6 minutes walk test, he walked 505 meters with a 10 rate on a Borg scale. And the International Physical Activity Questionnaire puts him in a moderate physical activity. And because he had a negative exercise ECG, he was able to perform stationary cardiac rehabilitation. The rehab included 21 days of daily easy strength exercises, half an hour, interval cycling in 3-to-1 protocol, which means that 3 minutes he had a 50 watts and 1 minute 95 watts cycling, pool exercise therapy. After that, he was advised to walk as much as he can, so he walked total 91 kilometers in those 21 days, making over the 10,000 met minutes and over 12,000 kilocalories expenditure of energy, which exceeded minimum weekly recommendation. The important thing here is to say that he also was in nutrition counseling, weight management, blood pressure, and psychosocial management to incorporate in all this therapy. After the second phase, after 21 days of rehabilitation, his 6 minutes walk test was greater for 90 meters. Borg was unchanged, but the improved efficiency on the same scale. BMI was reduced, and the important thing that he was set to class 1 of the New York Heart Association, which means that he had no symptoms of the Barlow disease or mitral regurgitation at this point already, and functional capacity was significantly improved. After that, he came into phase 3 of cardiac rehabilitation, for which he was educated to do 3 to 5 times weekly moderate aerobic activity, blood pressure control, weight management, regular echocardiographic follow-up, educational symptoms recognition, and the important thing for him is that to understand that rehabilitation continues beyond hospital and that it lasts for life. Clinical implications of this case is that the early surgery prevents dysfunction of the left ventricle. Valve repair is superior to replacement because it shows better results in the long range. Minimally invasive techniques optimize recovery. Structured cardiac rehab improves mortality and quality of life. And for that reason, physiotherapy is not optional but essential for this kind of disease. And for me to conclude is minimally invasive mitral valve repair combined with structure and progressive cardiac rehabilitation enables faster recovery, superior functional improvement, better quality of life, and reduced long-term cardiovascular risk for the patient. I thank you for that's all for me.
Thank you, dear Marin, for sharing this interesting case study and its important clinical insights. Our next presentation focuses on rehabilitation following ACL reconstruction, with particular emphasis on the influence of demographic and physiological factors on rehabilitation outcomes. So the presentation is titled Rehabilitation After ACL Reconstruction and the Influence of Various Factors such as Gender, Age, and Body Mass Index, a literature review. The presenter is Valentina Dushi, PhD candidate. So Valentina, the floor is yours.
Thank you for your introduction, Professor Kovačič. Good morning, and thank you for the opportunity to present my work. Today I will present a literature review, Rehabilitation After ACL Reconstruction, Influence of Gender, Age, and BMI. The aim of this review was to analyze how demographic factors influence rehabilitation outcomes after ACL reconstruction. A brief background. Anterior cruciate ligament injury is one of the most common injuries, particularly among athletes and active individuals. It frequently happens in sports involving pivoting, sudden change of direction, jumping and landing, such as football, basketball, and skiing. The incidence rate is about 68.6 cases per 100,000 persons per year. All through ACL reconstruction surgery restores mechanical stability. Surgery alone does not ensure full recovery. Postoperative rehabilitation is essential for restoring strength, neuromuscular control, and functional performance. Recent rehabilitation approaches have shifted from time-based protocols to criteria-based progression, emphasizing individualized rehabilitation strategies. The purpose of this literature review was to analyze scientific evidence regarding rehabilitation outcome after ACL reconstruction. The review focuses on 3 demographic variables: gender, age, and body mass index. Specifically, the study evaluates how these factors influence muscle strength, functional performance, and readiness to return to sport. As mentioned, this study is a literature review, including studies published between 2015 and 2025. The database is research included PubMed, Medline, Scholar, Google, and ResearchGate. The research strategy used keywords such as ACL reconstruction, rehabilitation, gender differences, age factor, BMI, return to sport. The review included randomized controlled trials, cohort studies, systematic reviews, and meta-analysis focusing in rehabilitation outcome. The study selection process followed a structured literature review approach. Initially, from 160 articles were identified from databases research. After removing duplicates, after removing articles that didn't meet the inclusion criteria, only 12 studies were included in this literature synthesis. Several studies have investigated the role of age and gender in rehabilitation outcome after ACL reconstruction. For example, Niger and colleagues reported that demographic factors such as age, gender, are significant predictors of functional outcomes following surgery for ACL reconstruction. Similarly, Ageberg and colleagues found that female patients tend to report poor patient-reported outcomes compared with males. Other studies suggested that female athletes may demonstrate different neuromuscular control strategies and movement patterns, which may contribute to re-injury risk. Research by Paterno and colleagues also indicated that younger athletes may return to sport earlier, but this group also present a higher risk of secondary ACL re-injury. Together, these findings suggest that demographic characteristics should be considered when planning rehabilitation programs. Body mass index is also another factor that has been associated with rehabilitation outcomes. Studies have shown that patients with higher BMI may experience slower functional recovery and greater mechanical load on the knee joint during rehabilitation. For example, Fang and Louis reported that obesity was associated with poor postoperative outcome and longer hospital stays. Zhao and colleagues found that higher BMI was related to delayed rehabilitation and reduced functional performance. A big registry data from Sneinborgson and colleagues also demonstrated that BMI about 25 was associated with increased risk of early ACL revision surgery. Similarly, Weda and colleagues developed a predicted model showing that age, gender, BMI, and quadriceps strength together can predict the recovery after ACL reconstruction. These findings suggest that BMI may influence both rehabilitation progression and long-term outcomes after ACL reconstruction. Based on literature, modern rehabilitation after ACL reconstruction should focus on several key principles. These include restoring full range of motion, strengthening of the quadriceps muscle, involving neuromuscular control and movement quality. Rehabilitation should also progressively prepare the patient for safe return to sport. This literature consistently shows that demographic factor influence rehabilitation outcomes. Female athletes may experience slower neuromuscular recovery due to biomechanical differences. Younger athletes may recover faster, but they have an increased risk of re-injury. Patients with higher BMI experience slower rehabilitation due to increased joint loading. These findings support the need for individualized rehabilitation strategies. Despite increasing research on this field, several gaps remain. Many studies are retrospective in nature or cross-sectional, with limited understanding of long-term recovery. Demographics such as gender, age, and BMI are often studied separately rather than together, and BMI is rarely analyzed as the primary predictor of rehabilitation outcome. In addition, many studies rely mainly on patient-reported outcomes instead of objective functional tests. Future research should focus in prospective longitudinal studies following patients over longer periods of time, ideally 12 to 24 months. There is also a need to develop personalized rehabilitation programs that consider demographics and functional factors. Predictive models integrating biomechanical, demographic, and psychological variables may help clinicians better predict rehabilitation outcomes. Overall, the literature suggests that rehabilitation is the most important determinant of long-term recovery after ACL reconstruction. Successful outcomes depend on restoring quadriceps strength, improving neuromuscular control, and ensuring psychological readiness. However, recovery trajectories vary between individuals. The evidence highlights the importance of personalized rehabilitation approaches. In conclusion, this literature review shows that gender, age, and BMI significantly influence rehabilitation outcome after ACL reconstruction. Shows also that criteria-based rehabilitation appears to be more effective than traditional time-based protocols. Integrating demographics and psychological factors in rehabilitation planning improve recovery and reduce re-injury risk. Future researchers should focus more in prospective studies and personalized rehabilitation models. Thank you for your attention. I would be happy to answer any question or
Thank you, dear Valentina. Thank you for presenting this interesting review and highlighting important factors influencing rehabilitation outcomes after ACL reconstruction. So yes, the discussion will be at the end, at the very end. Our final presentation in this 10th panel explores an interesting intersection between physiotherapy, biomechanics, and sports performance, specifically within equestrian sports. The presentation is titled Physiotherapy and Biomechanics in Enhancing the Performance of Horses and Riders. The presenting authors include Jana Huniec, Vesna Hodic, Mateja Znika, and Jasminka Potočnjak from University North. So Jana, please begin. The floor is yours.
Good morning, everyone. Thank you very much for your introduction. Today I will represent to you my team, which is Synergy of Biomechanics and Physiotherapy in Improving the Performance of Horses and Riders. Well, first question is, why even focus on the rider? Riding is often discussed from the horse's perspective, but movement quality begins with rider itself. That means the seat of the rider must reflect stability, balance, and body control, which means the horse responds to the rider's seat, and the horse actually biomechanically transmits what the rider is giving from its seat. What exactly is an effective seat? Well, when it comes to that, an effective seat should include a neutral pelvic alignment, a stable but adaptable core of a rider, and most important is that rider must have even weight distribution. Well, rider must be controlled and relaxed in his posture, which means the rider must not be stiff. He just has to control his stability. Well, postural control in riding actually means that maintaining balance during movement is crucial for safe riding and for rider itself. Controlling the body of rider in canter must be center of the mass. So the rider's body, the rider's seat in the saddle must be centered so that the horse is more stable, more secure. Also, riding is not just when you sit on the horse and that's it. Rider has to be very controlled and he has to have huge control over itself, which means he has to continuously adjust small movements of the core. Well, riding requires dynamic and not static stability, which means rider is always in some kind of movement when it's on the horse. Well, core stability and trunk control, core control is crucial for the rider, which actually means that it involves deep abdominal muscles, active back extensors, and huge belly control. And with all that, rider must have coordinated breathing and must not be stiff. Why? It's because stable core actually allows efficient force transfer and better movement precisions. Okay, now we are coming to the very important part, which is actually correct rider posture in the saddle. We can see on this picture example, how should rider sit on the horse? So, correct rider posture should align with ear. So ear, then straight down to the shoulder, then to the hip, and then a little bit behind the heel. Why? Why is that actually important? Well, neutral pelvic position, which we will have in this actual posture, will allow to optimal load transfer and even weight distribution. We have to have in mind that the rider's weight shifts to the horse center of gravity forward, which is why proper rider posture in the saddle is very important. Even the slightest changes in the rider position can affect the balance and symmetry and the quality of the ride. Gallop, if you ask me, is actually the best gives the best synchronization between rider and the horse. Yes, it is the fastest, but because of that, the rider have a lot of control of his body and of the horse, which is actually very good for the balance itself. When it comes to the when it comes to the dynamic balance, the ability of continuously adapt to the horse's movement while maintaining posture symmetry and control of the rider's center of the mass is the crucial thing rider must have. Okay, we are coming to the role of the pelvis of the rider itself. Well, the pelvis is the key connection point. Why? It transfers movement, it absorbs motion, and it maintains alignment. When the rider have a loss of pelvic control, that often leads to composition and the lower back of a rider. Common issues in riders are asymmetrical weight distribution, which can get better with exercise. Lateral core shift, which means the riders shifts or more on to the left or more to the right. It depends which side is better of a rider, which is not so good. Lumbar collapse and excessive rigidity. Okay, consequences of the poor stability of a rider actually leads to the increased lower back pain. It reduces movement precision. It leads to inefficient communication through the seat with the rider and the horse, and it leads to the fatigue and muscular overload. So now comes the question, how can riders improve that? Well, improving the strategies actually includes target core stability training, which is maybe most important, pelvic awareness exercises, which comes through the riding, correction of asymmetries, and mobility work for hips and thoracic spine. Small improvements in body of rider, actually in body control of a rider, can actually significantly improve seat quality. With practical implications, well, rider training should include off horses contingent and on the horse. Why? Because on the horse we can train a lot better. We can work a lot better on transitions, which leads to better performance, better stability. But of the horse, riders must work on his strength, on his balance, and on his muscles. While stability training should be progressive and individualized. That means every rider is a person for itself, like everyone else. Some riders are more stiff in the back, some riders are more stiff in legs. Some riders don't have enough condition to ride properly, etc., etc. So that is actually why should every exercise and not just training, it should be individualized. And the crucial thing is actually collaboration between trainers and physiotherapists, because I think physiotherapy can really help in riding and in every other sport, like in soccer, like in basketball, etc. Physiotherapy is crucial to be part of the horse riding as well. As a conclusion, I can say that the seat actually reflects the rider's functional stability. Posture control of a rider is essential for effective riding, and developing core stability actually really improves both performance and physical well-being of a horse and of rider. And that's it. Thank you very much.
Thank you so much, Jana, for the excellent presentation. So really insightful presentation and for highlighting the interdisciplinary also connection between physiotherapy, biomechanics, and equestrian performance. We now have a few minutes for the discussion. So if anyone has a question, please feel free to raise your hand or write your question in the chat. But while participants may still be reflecting on the presentations, perhaps I could start the discussion with questions. Of course, again, you are very welcome to post your questions in the chat, and I will read them out to our speakers. So first question to Shkurta. Based on your review, which of the exercise approaches appears to have the strongest evidence for improving functional outcomes in adolescents with idiopathic scoliosis?
Thank you very much for the question, Professor Tina. Yes, based on this review, so the Schroth exercise have the strongest evidence regarding treating idiopathic scoliosis patient. And also there are a lot of evidence which support more this treatment methods than other core and Pilates, but the existing evidence until now much more focused on Cobb angle and angles of transportation. In other parameters, the evidence is still lack, as also I presented in this review. But at the end, based on this review and also searching for other literatures, we can conclude that Schroth exercise have stronger evidence comparing to core and Pilates on improving spinal parameters or deformity that scoliosis causes.
Thank you. Another question from
Sorry, I was for the moment I was busy and I didn't read the question in the chat. Sorry.
Sorry. Let's check.
I don't know why I can't see.
No problem. I will pose the question. The further question. So from a clinical perspective, how should physiotherapists decide which exercise approach to use for individual patients?
Mm-hmm.
From your clinical perspective?
Yes, from my clinical aspects, I think the better is first to evaluate the patient and to see which kind of deformity have, and then based on clinical evaluation, we should exercise program should be individualized. So based on which parameters are much higher than other, because I know from my experience, I have a lot of patients where I used Schroth or I combined Schroth and core, and I have to improve in a Cobb angle and angle of trunk rotation. But again, the body appearance of that patient was not good. So the patient, when they look themselves in the mirror, were unsatisfied. So during treating the patient, we should focus in more clinical outcomes, not just in Cobb angle and angle of trunk rotation, because if the patient are unsatisfied with their body appearance, of course, then this can negatively affect quality of life and psychological well-being. So during treating patient, based on my experience and also based on evidence, the program of exercise should be individualized. So we can incorporate correction exercise from Schroth, or we can also incorporate if the patient, for example, have a limited spinal movement or pelvis asymmetry or other parameters. So we should incorporate more exercise than only Schroth.
So from your clinical perspective, do you think combining different exercise approaches could produce better outcomes than applying them individually?
yes, only it is good to combine different approaches, not only Schroth or Pilates or core. So combining as much as approaches depends on the clinical findings, achieved a better result than applying one approach alone.
Thank you, Shkurta. I checked the chat, so there are no questions for you. Maybe let's move to Mimosa.
Thank you very much, Professor Tina.
Thank you. Mimosa, what do you consider
There
the
is a
most...
question in chat. I've just posted it.
I don't see it. So sorry. Oh, yes. So Nagendra, yes. Which exercise method is most effective at reducing the Cobb angle and angle of trunk rotation, and why? How do these methods compare regarding their impact on spinal mobility?
Thank you for the question. Yes, the Schroth, sorry, I didn't remember exact question because I can't see in the chat.
So which
Can you repeat again? Sorry.
Yeah. Which exercise method is most effective at reducing the Cobb angle and angle of trunk rotation, and why do you think? Maybe this first part.
Yes, based on this review, Schroth exercise shown better result in reducing Cobb angle and angle of trunk rotation.
And sub question is why? Why do you think so?
I think because as I presented, so the key, the focus of Schroth exercise is in a 3D correct spinal movement. That's why Schroth exercise focused more in this exercise. So that's why Schroth exercise improved more Cobb angle and angle of trunk rotation, while core exercise and Pilates exercise focus more in strengthening muscles, improving posture and flexibility.
Okay, thank you so much. And the last part of the question was, how do these methods compare regarding their impact on spinal mobility? This was from Nagendra, sorry. How do these methods compare regarding their impact on spinal mobility?
So these methods, as I mentioned it before, Schroth exercise focused more in spinal correction, and these two other exercises focused more in strengthening the core. And combining this different approach may influence positive impact on clinical outcomes.
Thank you.
Sorry.
Thanks so much. We will move to Mimosa. So what do you consider the most important physiotherapy intervention in the early rehabilitation phase after ulnar nerve injury?
Thank you, Professor Tina. In the early rehabilitation phase of the ulnar nerve injury, in this case, a total rupture, as the most important physiotherapy intervention was protection and repair structures while maintaining joint mobility and muscle activation, gentle range of motion exercise, electrical stimulation, and functional hand training were used to prevent stiffness and support neuromuscular recovery.
Thank you. So how critical is early physiotherapy in optimizing neurological recovery in such cases?
As a complexity of this case, because the ulnar and nerve also and vein was a total rupture. The crucial physiotherapy in early rehabilitation is very important because help prevent muscle atrophy joint stiffness and deformitis while supporting neuromuscular re-education and functional recovery as a nerve regenerations.
Thank you. And the last question from my side, how important was this interdisciplinary collaboration between OT and PT in this process?
In this process, as I mentioned before, as a complexity of case, in the patient 25 years old, it's important to collaborate with colleagues. Interdisciplinary also plays a key role due to complexity, which involves ulnar vein and artery. Regarding to the literature, to patient with a rupture of ulnar nerve can to return to the work after 6 months after repair of nerve, but in this case, patients are ready to return to the work before 3 months of the rehabilitation. In this case, with the complexity of nerve and vein injury, regarding to the vascular surgeons, he preferred to return to the work after 6 months, and in this case we collaborated together and decided the patient is ready to return to the work after 6 months. I thought in this case, the patient achieved good food recovery early, and vascular surgeon recommended after 6 months. The collaboration is essential. I can hear, dear Professor Tina. I can hear you.
Professor Kovačič, we cannot hear you.
I'm so sorry. Just a quick note. Thank you, Mimose, for your answers. The questions in the chat, in my chat, do not appear in chronological order. So if I have accidentally missed anyone, please just feel free to let me know. We will continue with the third presenter. So the questions for Marin. So what specific considerations should physiotherapists keep in mind when designing rehabilitation programs after minimally invasive cardiac surgery?
Thank you for your question. When in the acute stage of rehabilitation, we need to have in mind the pain that the patient feels. So we must adapt to it. And we also need to understand that temporary respiratory impairment, because often it is the right-sided intercostal space that is used as entrance in the body. So the right-sided lung capacity is probably lower than the left-sided. So we need to focus on that kind of thing in some early rehabilitation status. And we need to keep in mind that we have limited thoracic mobility, and that provides us to tailor the rehab process in a way that is strictly for this one patient. And when we go to the next stage of rehabilitation, then we need to assess him what are his capabilities of a heart as a pump in that moment, and then we give him the exact amount of work in watts and in meds that we are challenging his heart, but we are not giving him something too hard to do to cause him some nausea or something. That will be the main things to think about when creating some rehab protocol.
So do you expect any different rehabilitation outcomes compared with traditional cardiac surgery approaches?
In the end, they are very similar, but the time amount between start of the rehabilitation and the end is it's a great difference. It's an important difference because after minimally invasive surgery, the time is significantly shorter for the rehab and for the full functional rehabilitation according to rehabilitation after classic sternotomy. So the time is the biggest because even in a half reduced time, we get to the same results comparing one way with another. So that's very important because the patient is earlier ready for his normal life after surgery like that.
Thank you so much. I have prepared some questions for Valentina, but I see they are from the audience in chat. The question from Jure Schwab, probably. Professor Valentina Dushi, what is your opinion on modern approaches to managing an ACL injury without surgery?
Modern research suggests that non-surgical management of ACL may be appropriate approach for certain patients, particularly for those with lower activity demands or non-participant in high-level pivoting sports. Conservative treatment typically focuses in a structured physiotherapy program that emphasizes quadriceps and hamstring strengthening, neuromuscular training, and movement control. However, surgical reconstruction still is commonly recommended for young, high-active athletes who wish to return to sports involving cutting or pivoting movements, because the risk of instability and secondary injuries may be higher. Therefore, the decision between surgical or non-surgical treatment should be individualized based on factors such as activity level, knee stability, patient goals, and functional performance. I hope that I have answered this question.
Thank you. There is another question from Denis Belic. You included studies with very heterogeneous designs, like registry cohorts, observational studies, systematic reviews, and predictive models, but I did not notice a formal methodological quality assessment or risk of bias evaluation. So how can we interpret demographic factors as true predictors of rehabilitation outcomes without controlling for study quality, rehabilitation protocols, and baseline functional status? So it was a question from Denis Belic for you.
I believe that one important limitation in the current literature is heterogeneity of study designs and methodology. The available studies included also randomized controlled trials, cohort registry analysis. In addition, the rehabilitation protocols and outcomes measure very consistently across the studies. This variability makes different comparison difficulties and limits the possibility for strong generalization of conclusions.
I have to unmute myself. Thank you for this also thoughtful question and for addressing an important methodological aspect. So issues such as study heterogeneity and risk of bias are indeed important when interpreting findings from the literature. So this highlights how careful we must be when translating research results
I have posted 2 questions.
into clinical questions. So another question I see for you, Valentina, was also from Turkic Aydin. So can you ask Professor Valentina what can be the cause of not having full range of motion after ACL reconstruction with meniscus repair when the knee is cold, but getting full range of motion after warming up the knee?
Depend first from I think it depends from demographic variables such as age, for example, that I mentioned. Also depend that if we have postoperative inflammation or swelling, arthrofibrositis or different pathologies are present or not. Also, the muscle weakness is an inhibitor of full range of motion, like quadriceps or hamstring tightness. Pain is also I think it's one of the main problems that can cause protective muscle guarding and range of motion restriction. Mechanism problems of the knee, for example, menisc injury, graft implementation, loss of bodies of the joint. The causes may be pretty wide, so specifically maybe I will prefer to answer by email, which I provided in the end of the slides.
Thank you so much. We now have to move to Jana because from Croatia, as we need to conclude the session on time. So since ideal posture is often not achievable in children with developmental disabilities or disorders, what would you consider the most important therapeutic priority during, for example, hippotherapy sessions?
Well, with hippotherapy, the most important, I would say it should be body control, core control and core stability. Core stability and trying to improve, I don't know how to say that, but trying to improve in kids and children and all riders that they don't have to be stiff. They can literally chill on the horse, and that way actually improves and the core and stability and movement of a rider in the saddle, etc., etc.
Thank you. And the last question for you, do you think physiotherapists should be more involved in professional equestrian teams?
Yes, definitely. Physiotherapists should be involved not only in professional equestrian teams, even in the maybe ranch or clubs where we don't have so many riders that compete. Why? Because it's for the well-being and of the horse and of a rider. And the biggest problem is that that's not so popular in Croatia, even maybe Slovenia, I don't know, but America, New Zealand, France, etc. They probably everyone have some contact with physiotherapist.
Thank you. So thank you to all presenters in this panel for their insightful contributions. So these presentations
Excuse me, I had one question about
Sorry, we have to conclude on time. So these presentations clearly demonstrate how physiotherapy continues to evolve as a research-driven and evidence-based healthcare profession with strong implications for clinical practice and rehabilitation science. So we will now continue with the next physiotherapy panel, starting punctually at 10:30. So welcome back, everyone, and thank you for joining the second physiotherapy scholarly panel of this conference session. In this panel, we will continue exploring research that bridges clinical physiotherapy practice and scientific investigation, highlighting how rigorous research methodologies contribute to improving rehabilitation outcomes and strengthening evidence-based physiotherapy. So before we begin, just a short reminder regarding the schedule. So as a moderator, timekeeping is never the most popular task, but it ensures that all presenters have equal opportunity to share their work. And of course, we have several presentations planned in this session as well. Therefore, each speaker will have a maximum of 10 minutes for the presentation. And I will give a short, quick reminder before the end of the allocated time and kindly ask all presenters to conclude within the time frame so that we can ensure fairness to all speakers and allow time also for discussion at the end. So really thank you very much for your cooperation in advance. So let us begin with the first presentation in this second panel this morning on physiotherapy interventions for chronic low back pain, one of the most prevalent musculoskeletal conditions worldwide. So the presentation is titled Comparative Analysis of Two Physiotherapy Intervention Programs in Individuals with Chronic Lower Back Pain. So the presenter is Suleiman Miftari, PhD candidate. So Suleiman, the floor is yours.
Hello, everyone. Thank you, Professor Tina, for the introduction and for moderating this session. My name is Suleiman Miftari. I am PhD student at University Alma Mater Europaea in the physiotherapy program, and I work as teaching assistant at the University of Pristina, and I also my practice in clinical. Today, I will present a comparative analysis of two physiotherapy intervention programs in the individuals with chronic low back pain. First, I will briefly present the background of this study. Chronic low back pain is one of the most common musculoskeletal disorders worldwide and represents a major cause of disability. As a result, patients with chronic low back pain often experience persistent pain and functional limitation and decreased quality of life. The purpose of this study is to compare two physiotherapy programs in chronic low back pain. This study was designed a randomized comparative clinical study. A total of 60 participants with chronic low back pain, 30 patients per group. The treatment period lasted 6 weeks. Assessment outcomes was performed at 3 different time points at the baseline before the treatment, after 3 weeks of therapy, and after 6 weeks after treatment. Statistical analysis performed using SPSS. The study included adult participants aged 18 and 65 years. All participants was diagnosed with chronic low back pain longer than 12 weeks. And all participants are randomly allocated in 2 groups. It means 30 patients for each group. According to the intervention per program, this study included 2 physiotherapy programs, McKinsey-based program and exercise-based program. Group 1 received treatment McKinsey-based program combined with passive modulitis, tense thermotherapy, lumbar traction, and structure walking program. And whereas Group 2 exercise program received a treatment program with therapeutic exercise with combined the same additional modality therapy. This treatment lasted 6 weeks. During the first 3 weeks, the treatment received 5 sessions a week, and after the next 3 weeks, continued in the private clinic. Maximum of this session have been 24 treatments. What is important to say is main intervention is in Group 1. McKinsey method is focused in repeated spinal movements and directional reference exercise, whereas the Group 2 focused therapeutic exercise is more lumbar mobility and trunk muscle strengthening. According to the additional modalities, both groups thermotherapy 15 to 20 minutes, tense lumbar traction, and walking programs 5 days per week. In the study, outcome measurements was conducted. For example, pain intensity was evaluated using visual analog scale. Functional disability related to low back pain was assessed using functional disability. Lumbar flexibility using is used finger to floor test, and self-esteem was evaluated using Rosenberg self-esteem scale. Moving to the results. This table presents these graphs present the baseline characteristics of a participant were included in the study. The graphics the analysis showed both groups are comparable before the treatment according in the body mass index, age, and both sex. This slide present analysis show both intervention, physiotherapy intervention show a slight improvement all the weeks. This table present the result for functional disability. Also here, both groups, especially McKinsey McKenzie treatment method treatment show slight improvements on the week 3 and the 6th week. These slides present the lumbar of flexibility. Similarly, group 1 McKenzie group also once again shown a slight great improvement all the time. And last table present the result of a self-esteem. Self-esteem at the baseline was comparable off-pole groups, and after six weeks show significant slight great improvement of both groups. In this study, in the result of the study, the study shown significant improvement outcomes. These results are consistent with previous research, and I would say it's a no statistically significant difference between was found in this treatment. Despite the positive findings, some limitations should be considered. First, the study was conducted in single center to study design, and second, the study was relatively a small sample size, nor 60%. In addition, the study was short-term follow-up period, and future studies should consider it larger sample size and longer term outcome. In conclusion, both interventions, physiotherapy intervention, has resulted in improved pain, disability, and flexibility. Both on the results, both approaches can be considered effective clinical options managing for chronic low back pain. Here are some references. Thank you for attention, Professor.
Thank you. So,
I will be
despite
happy
some
for your
minor
questions.
technical difficulties, likely due to internet connection, thank you very much for your presentation, dear Suleiman, and for highlighting important aspects of physiotherapy intervention in management of chronic low back pain. So the next presentation examines biochemical indicators of muscle damage, an area increasingly relevant in sports medicine and rehabilitation sciences. The presentation is titled Detection of Muscle Damage by Biochemical Methods, presented by Roko Brlek with co-authors Professor Manuela Kušec and Professor Goran Bobic. We are looking forward to your presentation. So the stage is yours.
Yes, good morning from Croatia. It's morning. It's still morning, isn't it? I'm Manuela Kušec from University of Applied Sciences Ivanić-Grad, and today I will present the topic detection of muscle damage using biochemical markers. In this presentation, sorry, is it up? In this presentation, I will discuss the structure of skeletal muscle, types of muscle injuries, the biochemical mechanisms of muscle damage, and the laboratory markers used for their detection. Skeletal muscle injuries are very common, especially in sports and rehabilitation. And early detection of these injuries is important for proper treatment and for prevent further damage. In addition to clinical examination and imaging methods, biochemical markers play an increasingly important role in the detection of muscle damage. These markers are substances that are released into the bloodstream when muscle cells are damaged. By measuring these markers, clinicians and physiotherapists can better understand the extent of muscle injury and monitor the recovery process. The aim of this study was to present the main biochemical markers used in detection of skeletal muscle damage. In addition, the study analyzes their diagnostic significance and their application in sports medicine and rehabilitation. Another important goal was to highlight how laboratory findings can be used to monitor muscle recovery and support the rehabilitation process. Before discussing biochemical markers, it's important to explain the structure of skeletal muscle. Skeletal muscles are an important part of the locomotor system and are responsible for body movement. They are composed of muscle fibers, also called myocytes, which are specialized cells capable of contraction. Inside these fibers are myofibrils that are organized into sarcomers, which represent the basic functional units of muscle contraction. The interaction between the proteins actin and myosin allows the muscle to contract and generate force. During physical activity or trauma, skeletal muscles can be exposed to different types of injuries. One of the most common injuries is muscle strain, which occurs when muscle fibers are overstretched or slightly torn. More severe injuries include partial muscle tears or complete muscle rupture, which scientifically affect muscle function. Muscle injuries are also occur as contusions, usually caused by direct impact or as muscle fatigue, which develops after prolonged or increased activity. To better understand these injuries, it's important to explain the biochemical process that occur during muscle damage. When muscle damage occurs, the permeability of the muscle cell membrane increases. This allows calcium ions to enter the cell, which disrupt the normal balance inside the muscle fibers. The increased concentration of calcium activities proteolytic enzymes that start breaking down structural proteins within the cell. As a result, intercellular components such as enzymes and proteins are released from the muscle cells into the bloodstream. These substances can then be detected in laboratory tests and used as biochemical markers of muscle damage. The following slide illustrates the mechanism of muscle damage and the release of their biochemical markers. This diagram illustrates the main mechanism of muscle damage. Well, first, a muscle injury leads to disruption of muscle cell membrane. This allows calcium ions to enter the cell, which activates proteolytic enzymes. These enzymes began to break down cellular structures, leading to further damage of the muscle fibers. As a result, intercellular proteins such as creatinin kinase, lactate dehydrogenase, and myoglobin are released into the bloodstream, where they can be detected through laboratory tests. Because these proteins enter the bloodstream, they can be measured using laboratory diagnostic methods. Well, several biochemical markers can be used to detect muscle damage. One of them is creatinin kinase. Well, creatinin kinase is considered the most sensitive and widely used marker of skeletal muscle injury. Then lactate dehydrogenase is also released during cellular damage, although it is less specific. Myoglobin is an early marker that appears quickly in the bloodstream after muscle injury. Additional enzymes such as AST and aldose can also increase in cases of muscle damage and help support the diagnosis. Laboratory detection of muscle damage is primarily based on blood tests that measure enzymes and proteins such as creatinin kinase, lactate dehydrogenase, myoglobin, and AST. Also, urine analysis can be used to detect myoglobin, especially in severe muscle damage or rhabdomyolysis. Monitoring the dynamics of these markers helps assess the severity of injury and the recovery process. In clinical practice, laboratory results are usually interpreted together with imaging methods such as MRI or ultrasound. Well, clinical relevance. The early detection of muscle damage is very important in both clinical practice and sports medicine. Biochemical markers help healthcare professionals identify muscle injuries at an early stage and assess their severity. They also allow clinicians and physiotherapists to monitor the recovery process and evaluate the effectiveness of rehabilitation programs. In sports medicine, these markers are particularly useful for prevent overtraining and ensuring a safe return to physical activity. In this context, physiotherapists also play an important role in interpreting these laboratory findings. By analyzing laboratory results, physiotherapists can better understand and conduction of muscle and adjust rehabilitation programs accordingly. These markers also help physiotherapists monitor recovery, control training load, and reduce the risk of recurrent muscle injuries. But therefore, collaboration between physiotherapists, physicians, and laboratory specialists is essential for effective treatment and rehabilitation. And in conclusion, biochemical markers represent an important tool for detecting muscle damage. Markers such as creatinine kinase and myoglobin are particularly useful for identifying muscle injury and monitoring recovery. Laboratory diagnosis can help healthcare professionals plan rehabilitation program more effectively. Finally, interdisciplinary collaboration between clinicians, physiotherapists, and laboratory specialists is crucial for improving diagnosis and treatment outcomes. And finally, I will end with Hippocrates' sentence, wherever the art of medicine is love, there is also a love of humanity. And that's all from me.
Dear Manuela, thank you for highlighting this important perspective on the biochemical assessment of muscle damage and its relevance for rehabilitation science. So our next presentation focuses on preoperative chest physiotherapy in patients undergoing elective cardiac surgery. So highlighting the importance of physiotherapy within multidisciplinary or interdisciplinary perioperative care. So the presentation is titled The Effectiveness of Preoperative Chest Physiotherapy in Patients Undergoing Elective Cardiac Surgery. The presenter is Arven Krasniqi, our PhD candidate. So Arven, the floor is yours.
Thank you very much, Professor Tina. Good morning and good afternoon, and thank you for the opportunity to present at the 14th Annual Conference of European Leaders, Researchers, and Science and Arts. My name is Arven Krasniqi, and today I will present our study on the effectiveness of preoperative respiratory physiotherapy in patients undergoing elective cardiac surgery. Postoperative pulmonary complications remain among the most common and clinically significant challenges following cardiac surgery. This study aimed to evaluate whether structured preoperative respiratory training can improve postoperative outcomes and reduce hospital burden. Global clinical burden. This figure from Mutiha and colleagues, published in the Journal of the American College of Cardiology in 2022, illustrates the global burden of cardiovascular disease measured by a standardized disability-adjusted life years. This global perspective underscores the importance of optimization preoperative management in cardiac patients, including preoperative strategy that may reduce postoperative complication. Postoperative pulmonary complication, or PPC, are the most frequent and clinically significant events following cardiac surgery. They common including atelectasis, pneumonia, pleural effusion, and respiratory failure. These conditions are closely associated with prolonged mechanical ventilation, longer ICU stay, and extending hospitalization. From the pathophysiological perspective, general anesthesia, post-sternotomia pain, diaphragmatic dysfunction, and reduced lung expansion contribute to alveolar collapse and impaired gas exchange. Additionally, certain patient-related factors increase the risk, such as advanced age, smoking history, and chronic pulmonary disease like COPD. Rational study rehabilitation concept. Rehabilitation respiratory physiotherapy represents a target preventive strategy aimed at strengthening inspirator muscle, improve lung expansion, and increasing functional respiratory reserve. International evidence suggests that structured inspirator muscle training before cardiac surgery can reduce the incidence of postoperative pulmonary complication, shorten hospital stay, and enhance recovery. However, despite the growing international data, there is a local evidence in Kosovo region the implementation and effectiveness of structured preoperative respiratory programs. This gap highlights the significance of the present research. Purpose and goals. The aim of the study was to evaluate the effectiveness of preoperative respiratory physiotherapy in patients undergoing elective cardiac surgery. The primary objective was to determine whether structured respiratory physiotherapy could reduce the incidence of postoperative pulmonary complication, which remain among the most common causes of delayed recovery. Additionally, we aim to analyze whether this intervention could shorten the length of hospital stay and reduce the need for postoperative oxygenotherapy. Methodology and study design. This was a prospective causes experimental study conducted at the University Clinical Center of Kosovo, specifically at the Clinical of Cardiac Surgery. A total of 69 patients undergoing elective cardiac surgery were included. The intervention group consisted of 35 patients who received strong preoperative respiratory physiotherapy, with 34 patients formed the control group. The mean age was 56.8 years, with a predominance of males who responded approximately 74% of the sample. FRP intervention. The structured preoperative respiratory physiotherapy program includes 4 main components. The first, inspirator muscle training using resistance device to increase inspirator strengthening and improve functional pulmonary reserve before surgery. Second, diaphragmatic breathing techniques to promote controlled ventilation and optimal lung expansion. Third, intensive spirometry to stimulate maximal inspiration and prevent alveolar collapse. Finally, early mobilization to enhance ventilation and accelerate functional recovery. Variable and statistical analysis. The independent variable was participation in preoperative respiratory physiotherapy, categorized as yes or no. The primary outcomes variable include the occurrence of postoperative pulmonary complication, length of hospital stay measured in days, and the need for postoperative oxygenotherapy. These outcomes were selected because they are clinically meaningful indicators for recovery and postoperative respiratory status. Statistical analyses were performed using SPSS version 27. Categorical variables were analyzed using the chi-square test, with continuous variables were compared using the independent sample t-test. Preoperative clinical outcomes. Statistical significance difference were observed in the incidence of postoperative pulmonary complication and in the length of hospital stay, both favoring the group that received respiratory physiotherapy with p-values less 0.001. The need for postoperative oxygenotherapy was lower in the intervention group. However, this difference did not research statistical significance. Similarly, mechanical ventilation lasting more than 24 hours was less frequent in the intervention group, but without statistical significance. Postoperative pulmonary complication. The occurrence of postoperative pulmonary complication differed markedly between the two groups. Patients who received preoperative respiratory physiotherapy had a substantial lower frequency of pulmonary complication compared to the who did not receive this intervention. Specifically, pulmonary complications were observed in 31.4% of patients in the intervention group, whereas in the control group, this percentage was 76.5%. Statistical analysis using the chi-square test confirmed that this difference was highline statistical significance, and with p-value of less than 0.001. This finding demonstrates a strong association between preoperative respiratory physiotherapy and reduction of postoperative pulmonary complication. Length of hospital stay. Patients who underwent preoperative respiratory physiotherapy had a significantly shortened duration of hospitalization compared to the control group. The mean length of stay was 7.43 days in the intervention group, whereas 9.59 days in the control group. These results suggest that preoperative respiratory physiotherapy contribute not only to clinical improvement, but also to more efficient utilization of hospital resources. Prediction of postoperative oxygenotherapy. The overall model was statistically significant, indicated that the incidence variables contribute to prediction the outcomes. Preoperative respiratory physiotherapy had a negative coefficient, suggesting a potential protective effect. However, this association did not reach statistical significance. In contrast, smoking status emerged as a strong predictive factor. Smokers were approximately 6 times more likely to require postoperative oxygen therapy. These findings highlight the importance of smoking as a modifiable risk factor influencing postoperative respiratory outcomes. Discussion. This study demonstrates that preoperative respiratory physiotherapy significantly reduced postoperative pulmonary complication and shortened hospital length of stay in patients undergoing elective cardiac surgery. The reduction in postoperative pulmonary complication may be explained by improving diaphragmatic strength and enhanced alveolar ventilation. The shortened hospital stay aligned with evidence from pre-rehabilitation program. Although the need for oxygen therapy did not reach statistical significance, smoking status emerged as a strong predictor factor. In line with ERA's protocol, enhanced recovery after surgery, approach the results support the integration of structured preoperative respiratory into standard preoperative protocols. Limitation and conclusion. Despite the positive results, the study has several limitations. The non-randomized design, the relative small sample size, and age difference between the group might have influenced the findings. Therefore, randomized control trials with larger sample are needed. In conclusion, preoperative respiratory physiotherapy is significantly reduce postoperative pulmonary complication and shorten hospital stay. It represents a lower risk intervention that is recommended for routine integration into preoperative protocols. Thank you for your attention, and future cardiac surgery should be integrated structured preoperative respiratory physiotherapy as a structured component of preoperative optimization. Thank you very much.
Thank you, dear Arben, for highlighting the clinical importance of preoperative physiotherapy in improving outcomes for patients undergoing cardiac surgery. So we now move to a presentation addressing physiotherapeutic rehabilitation in patients with ankylosing spondylitis, a condition where physiotherapy plays a crucial role in maintaining function and quality of life. So the presenter is Bayram Shitti, our PhD candidate. So Bayram, please begin with your presentation.
Hello, Professor Tina. Hello, dear colleagues. Today I will present my research titled Structured Physiotherapy in Ankylosing Spondylitis, Enhancing Function and Quality of Life. Ankylosing spondylitis is a chronic inflammatory rheumatic disease belonging to the group of axial spondyloarthritis. It mainly affects the spine and the sacroiliac joint, causing persistent pain, morning stiffness, and progressive loss of spinal mobility. Over time, it can significantly reduce physical function, work capacity, and quality of life. According to the ASAS EULAR 2023 guidelines, physiotherapy and structured exercise remain essential elements of comprehensive disease management. The aim of this study was to evaluate the effectiveness of physiotherapy rehabilitation program on clinical and functional outcomes in patients with ankylosing spondylitis over 12-week period. The research focused on three main outcomes: pain reduction, functional improvement, and quality of life. We have three hypotheses. Hypothesis 1, physiotherapy combined with medication leads to greater pain reduction than medication alone. Hypothesis 2, higher physical activity levels are associated with a better functional improvement. And hypothesis 3, age and duration participation in physiotherapy influence quality of life. Data were collected at the rheumatology clinic in Pristina between March and June 2025. The study included 60 patients, adults with a confirmed diagnosis of ankylosing spondylitis. Participants were randomly selected and divided in two groups equal. One group received pharmacological therapy combined with structured physiotherapy program, while the second group continued with pharmacological treatment alone. Several validated and internationally recognized instruments were used. VAS measure pain intensity, BASFI for evaluating functional status, and SF36 for assessing quality of life, and self-reported daily physical activity measured in minutes. Data analysis was performed using SPSS version 26.0, first processing data, screening, analysis, and the result. Three main statistical methods were applied: independent t-test to compare main pain intensity between the two groups, Pearson correlation to examine relationship between physical activity and functional improvement, and multiple regression to examine the relationship between physical activity and functional improvement. All analyses were performed with a significant level of alpha equal 0.05. Among the 60 patients included in the study, 73.3% were male, which reflect the typical gender distribution of this disease. The mean age of the participants was 50.5 years, while the average duration of the disease was about 19 years. Extra-articular manifestations were observed in 83.3% of patients, including uveitis, inflammatory bowel disease, and urinary tract infections. These findings highlight the systematic and complex nature of ankylosing spondylitis. The result showed no statistical difference in pain intensity between the two groups. The mean pain score was 5.10 in the physiotherapy plus medication group and 5.26 in 27 in medication only group. The p-value was 0.669, indicating that the addition in physiotherapy did not significantly reduce pain in this sample. Therefore, the first hypothesis was not confirmed. Positive and statistically significant correlation was found between the level of physical activity and functional improvement. The Pearson correlation coefficient was R equal 0.254 with P equals 0.031. This suggests that the patients who engaged in higher level of physical activity experienced better functional outcomes. Thus, the second hypothesis was confirmed. Multiple regression analysis identify two significant predictors of quality of life. Age had a negative effect, meaning older patients reported lower quality of life. In contrast, longer participation in physiotherapy had a positive effect. The overall regression model was statistically significant, F equal 3.612 and P equal 0.034, confirming the third hypothesis. In summary, three main findings emerged from the study. First, structured physiotherapy did not lead to additional pain reduction. Second, higher physical activity levels were associated with improved functionality. And third, age negatively affect quality of life, while longer physiotherapy participation improve it. These findings highlight the important role of physiotherapy in long-term functional management. From a clinical perspective, these findings suggest several practical implications. Physiotherapy programs should emphasize long-term physical activity and mobility rather than focusing only pain reduction. Programs should be individual based on the patient's age, functional levels, and capabilities. In addition, patient education and motivation should become key component of treatment. Several limitations should be acknowledged. The cross-sectional design does not allow causal conclusions. Reliance on self-reported data may introduce reporting bias. The study also lacked objective inflammatory markers and radiographic parameters, and it was difficult to fully control the exact intensity and duration exercise performed by patients. In conclusion, structured physiotherapy combined with pharmacological therapy did not lead significantly reduce pain. However, it plays a crucial role in improving functional abilities and enhancing quality of life. Long-term physiotherapy program that encourage regularly physical activity are strongly recommended, especially for elder patients who are at high risk of functional decline. Thank you for your attention and any question.
Thank you, Bayram, for emphasizing the crucial role of physiotherapy in maintaining function and mobility in patients with ankylosing spondylitis. Sorry.
Yes.
So our final presentation in this panel explores an integrative perspective on abdominal therapy and its potential role in regulating multiple physiological systems. The presenter is Minodora Cecilia Kader. So Minodora, the floor is yours.
Hello, and thank you for the opportunity to present today. Short to me, I study physiotherapy at the Alma Mater Vienna in Austria, and I've been a medical massage therapist since over 10 years. In my clinical work, I frequently see patients with complex abdominal complaints. The aim of this presentation is not to introduce finalized therapy, but to raise awareness of the abdomen, a regulatory hub where several physiological systems interact. Many patients present with symptoms that cannot be explained by a single organ system. Instead, digestion, breathing, stress regulation, and fascial tension often interact. This raises a simple question. Could the abdomen play a more central regulatory role than we usually assume? Today, I will briefly present two clinical observations, the concept of the abdominal nexus, scientific evidence of abdominal manual therapy, and the Kader abdominal therapy as a developing clinical framework. I would like to open with a short historical perspective, as the manual treatment of the abdomen is not new. In Chinese medicine, the abdomen relates to the dantian, a center of internal regulation. Also, in Japanese bodywork, abdominal diagnosis and treatment are known as hara therapy. Although these traditions developed long before modern physiology, they consistently emphasize the regulatory importance of the abdominal region. And today, modern research is beginning to explore possible physiological mechanisms behind these observations. For today, I brought to you two of my clinical observations. The first case involved a 92-year-old patient with chronic abdominal pain for almost 10 years. Multiple gastroscopies found no cause. His urologist referred him for manual abdominal therapy. After 3 sessions, the pain was gone. For the first time in years, he could sleep through the night. The pain has not returned for over a year, and he still attends occasional sessions because he feels more energetic and relaxed. The second case involved a patient with a Parkinson's disease and long-standing constipation. During one treatment session, the patient's hand tremor temporarily stopped for nearly an hour. Of course, this temporary effect cannot be interpreted as a treatment outcome. However, it suggested that manual abdominal stimulation might influence autonomic or neurovegetative regulation a point we will return to later. Constipation improved gradually. After about 7 sessions, the patient no longer required laxatives. Bowel movements occurred every 2 to 3 days instead of every 5 to 7 days. So these observations are not controlled evidence, but they raise an important question. Can mechanical stimulation of the abdomen influence several physiological systems simultaneously? These questions led to the concept of the abdominal nexus. So the word nexus describes a point where different systems meet and interact. The abdomen represents such a point, a functional intersection of several physiological systems. In this model, 5 axes interact. We have the stress physiology because physiological stress affects gut function. Then the fascial dynamics, since abdominal organs are embedded in the dense fascial network. Third is the lymphatic system, regulating fluid balance and immune responses. Fourth, the visceral mobility, as abdominal organs constantly move during breathing, and the autonomic regulation, which plays a central role in digestive activity. Clinical studies suggest that medical stimulation of the abdomen can influence several of these systems, supporting the idea of the abdomen as a regulatory hub. This system's perspective form the conceptual basis of Kader abdominal therapy. The strongest evidence relates to constipation and gastrointestinal motility. A meta-analysis reported 1.59 additional bowel movements per week and a reduction in intestinal transit time of about 21 hours. Constipation symptoms also decreased significantly, and randomized trials report similar findings, including about 70% reduction in constipation severity compared to placebo. The benefits were observed in several patient groups, including elderly patients, orthopaedic and intensive care patients receiving enteral nutrition. In ICU settings, so intensive care units, abdominal massage also reduced gastric residual volume, indicating improved gastric emptying. Further studies report improvements in post-stroke patients and children with cerebral palsy. However, systematic reviews emphasize heterogeneous study, quality, and protocols. The abdomen is closely linked to the autonomic nervous system, regulating digestion, cardiovascular function, and stress responses, consisting of 2 branches. We have the sympathetic system for activation and stress, and parasympathetic system for recovery and digestion. Autonomic balance is commonly assessed using the heart rate variability. A randomized study comparing manual lymphatic drainage, abdominal massage, and electrical stimulation reported measurable higher V changes. The high frequency component, the high frequency component increased while the low to high frequency ratio decreased, suggesting a shift toward the parasympathetic dominance. These changes occurred alongside improvements in gastrointestinal symptoms. So interestingly, I found a recent study by Lennartz et al. Was published a couple of days ago, which I integrated now in my presentation, investigated whether manual visceral stimulation of the vagus nerve in the abdominal region could influence functional brain networks. And the authors reported measurable changes in electroencephalography, derived network properties, suggesting that manual visceral stimulation may modulate brain network dynamics and further supporting the concept of the gut-brain interactions. Another perspective involves the fascial system. Abdominal organs are connected through fascia, mesenteries, and ligaments that allow movement and transmit mechanical forces. Fascia contains mechanoreceptors and nerve endings, meaning it participates in sensory and reflex processes. Changes in fascial tension may influence organ mobility, visceral reflexes, and pain perception. a randomized trial in multiple sclerosis patients with neurogenic bowel dysfunction reported improved bowel function after abdominal massage. And however, systematic reviews emphasize the need for more rigorous research. So the abdominal nexus concept forms the theoretical basis of cadera abdominal therapy. CAD explores whether targeted manual work in the abdomen can influence several interconnected systems. The approach integrates visceral mobility, fascial dynamics, lymphatic circuit autonomic regulation. At present, CAD should be understood as a clinical hypothesis and framework, research framework, not a finalized therapy. So current evidence suggests that mechanical stimulation of the abdomen can influence multiple physiological systems, including gastrointestinal motility, autonomic regulation, and possibly fascial dynamics. Future studies could evaluate outcomes such as bowel movement frequency, intestinal transit time, heart rate variability, gastric residual volume, abdominal circumference, and quality of life measures. But randomized control designs and standardized protocols will be necessary. To conclude, the abdominal nexus concept proposes that the abdomen functions as a regulatory intersection of these systems. So understanding these interactions may open new perspectives for manual therapy, rehabilitation, and neurogastroenterology. Further research is needed, though, to clarify this mechanism and evaluate emerging approaches such as cadera abdominal therapy. Thank you for your attention. I hope to return next year with the first study exploring the abdominal nexus concept and the cadera abdominal therapy. Thank you very much.
Thank you. Despite some internet connection difficulties, Minodora, thank you for this interesting presentation and for introducing this integrative therapeutic concept. So we now have a few minutes for discussion. If anyone has a question or comment, please feel free to post it in the chat. As a moderator, I also need to ensure a balanced discussion among the presenters. If we will not be able to address all questions from audience, I sincerely apologize, but we need to keep to the conference schedule. So there was one question for Suleiman from audience, from Nagendra. What is the core difference between motor control exercise and general strength training? And which program is more effective for immediate pain reduction?
Thank you, Professor. A question was asked by a colleague. Motor control exercise focuses on retraining the deep stabilizing muscles of the spine, such as the transversus abdominis and multifidus, with the aim of improving spinal stability and movement control. In contrast, general strength training focuses on strengthening the large global muscles of the trunk and improving over muscle strength and endurance. Regarding immediate pain reduction, both approaches can be effective. However, motor control exercise may provide slightly faster improvement in the early phase because it specifically targets spinal stability and the neuromuscular control. In the long term, both programs are considered effective in managing chronic low back pain. This is my answer.
Thank you so much. We will continue with Manuela. There is one question for Manuela Kuschetz from Valentina Dushi. What physiological processes lead to the release of muscle biomarkers into the bloodstream? Are you with us?
Yeah, I'm here. Physiotherapists can use biochemical markers such as creatinine kinase or myoglobin to monitor muscle stress and recovery. And what is another question? Myoglobin considered rapid because myoglobin is one of most how we said enzyme in a cell and in a very big concentrate, and when the membrane is damaged, a lot of them increase in bloodstream.
Thank you. So a question for Arben. Do you believe pre-rehabilitation programs should become a standard part of cardiac surgery pathways?
Thank you very much, Professor Tina. This is a very important question, especially for us in Kosovo, because I'm the first physiotherapist in clinical cardiac surgery. We both working as a physiotherapist in cardiochirurgy, and we didn't have any special protocols for this session, but apply physiotherapy just after operation. And this is very important if we apply to do exercise and before the pre-operation, during the patient waiting for.
I think we lost the connection. Okay, so let's move to Bayram. The question for Bayram. Could digital physiotherapy or tele-rehabilitation play a role in long-term management of this condition?
Thank you for your question, Professor Tina. This study used a cross-sectional observational design. The physiotherapy received by a patient was part of routine clinical care and not intervention administered by the research. Therefore, the study aimed to compare outcomes between patients exposed to physiotherapy and those receiving pharmacological treatment. I handle every day with patients with ankylosing spondylitis, and I must say that one thing is very clear, that if physiotherapy is started in early, it can be managed better. In the later stage of the disease, because ankylosing spondylitis is progressive and the deformity become slowly. So I suggest that the most significant improvement in pain or mobility or deformities is if the patient have ability to access supervised physiotherapy and structured physiotherapy. It's not important tele-rehabilitation or something, especially supervised physiotherapy.
Okay, thank you. So let's go back to Arben. Are you with us?
Yes, Professor, I am with us, but we have the problem with electricity, and I am from the phone. Sorry for interrupted.
So if you want to add something to your answer.
I continue to say it is very especially and necessary to continue and to do something for this fields, and I am try to prepare maybe some protocols or for this case, and to apply the physiotherapy before and after surgery in cardiac patient. And I think in conclusion, your question, I think, is very necessary to do in these fields.
Thank you.
And sorry for.
No problem. So, we have some questions for Minodora from the audience. So first one, which patient population would benefit the most?
So based on the current evidence, I think the most promising patient group appear to be the patients with functional constipation, neurogenic bowel dysfunction, and possibly patients with autonomic dysregulation.
So the second question is, are you planning a clinical study? Of course you do. So, but something to add from your side?
Yes,
so it will be your PhD, yeah?
A possible next step would be a pilot study, so evaluating bowel frequency, intestinal transit time, and the heart rate variability in patients with functional constipation.
And the last question, do you plan to standardize the technique?
Yes, this is one of the long-term goals. It is to define standardized treatment protocols so that the method can be evaluated and in controlled studies. So at the moment, the concept is based on my clinical observations and existing abdominal manual therapy approaches.
Okay, thank you so much. Before the final closing, the last question for the audience from Nagendra. Why is the abdomen, it's for you, Minodora, why is the abdomen considered the nexus for autonomic regulation?
Well, this is my approach for the abdominal therapy. So it is not considered nexus. I made this approach because there are those 5 axes that from my clinical observations, I saw interactions, and my next steps are to see if these interactions are simultaneously.
Thank you. So thank you to all presenters for their valuable contributions. As we see, the diversity of topics presented today highlights the breadth of contemporary physiotherapy research, ranging from musculoskeletal and cardiopulmonary rehabilitation to sports science and also integrative therapeutic approaches. And these studies clearly reinforce the importance of scientifically grounded, evidence-based physiotherapy for improving patient outcomes and advancing our profession. So thank you all for participating in this session. We will now continue with the next physiotherapy panel, but in between there will be a short break. So thank you for being with us, and all the best.
Thank you, Professor Tina.
Thank you very much.
Thank you.